Welcome back, everybody. David here again with Med School Bootcamp. So to round out our pharmacology section, we're going to talk about some very high-yield medications, including ACE inhibitors, angiotensin receptor blockers, and direct renin inhibitors. So remember, general system is we have the afferent arteriole, which blood comes in, it gets filtered, the Bowman's capsule, through the proximal convoluted tubule and the other portions of the nephron. Then the blood will actually leave through the efferent arteriole. And so these medications have a lot of effects on kind of this process. Now, very important, to really get the most out of this video, I need you to understand the renin, angiotensin, aldosterone system. We have a really great video about that, going into the detail of all of the steps. I really want you to see that again if you haven't seen it recently, or watch it for the first time, to really understand this process, because we're going to talk about the system and how these medications affect that system. Just as a super quick overview, we have some key players, right? We have angiotensinogen, which is then activated to angiotensin 1 by the renin enzyme. Angiotensin 1 then becomes angiotensin 2 by the ACE enzyme, or the angiotensin converting enzyme. And there are a lot of effects that angiotensin 2 has on the body. It can cause vasoconstriction of the vessels to increase our blood pressure. It can cause constriction of efferent arteriole to increase our filtration fraction. It can also cause release of aldosterone, which is a big player that we need to be familiar with here. Remember, aldosterone release is going to act to bring back sodium into the body, which then brings back more water. So patients who are volume depleted typically need more sodium to be reabsorbed. This can be problematic in things like heart failure, where our body is bringing back sodium even though we don't actually need more fluid. Additionally, angiotensin 2 can also increase release of ADH from the posterior pituitary, which can increase our water reabsorption. So again, if that's all unfamiliar to you, I really want you to check out that video to really get the most out of this pharmacology video, because now we're going to talk about what happens when we inhibit that system. So if we look at our medications here, we have three main groups we're going to talk about. ACE inhibitors, which include lisinopril, enalapril, and captopril. Just think about things that end in pril. Then we have our angiotensin receptor blockers, including valsartan and losartan. These tend to end in tan. And then finally, we have our direct renin inhibitors like aliskiren. And the mechanism of these is really what makes the difference. It's really what's going to help us answer test questions correctly. We need to know about the adverse effects, of course, but a lot of times these are classic questions where they will give you a table full of arrows, right? They'll have up arrows and down arrows, and they'll expect you to know where these medications act in the pathway and determine, would we expect a molecule to be elevated or decreased if a patient was receiving this medication? So the first one that's most commonly tested is going to be ACE inhibitors. So the mechanism includes inhibition of ACE, the angiotensin converting enzyme. Remember, in our RAS system, angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. So if we give an ACE inhibitor, we decrease the conversion of angiotensin 1 to angiotensin 2, ultimately dropping our angiotensin 2 levels. Now, remember, we talked about the RAS system and how many things angiotensin 2 actually does in the body. It does a lot of things. So now we have to work backwards. Think about it in the reverse order. Well, if we know what angiotensin 2 does, because we've learned about the RAS system previously, what happens if we don't have that molecule? Well, one of the things that's going to happen is that we're going to have an increase in renin secretion from the body. And why is that? It's due to a loss of negative feedback. Remember, from basic biology and biochemistry, when we have a substrate downstream, we have a lot of that substrate, it has something called negative feedback, where it'll go back and inhibit the production of that molecule. However, if our angiotensin 2 is low, we're actually going to lose this process. We're not going to get this inhibition, and that's going to cause our renin to be high because we lose that negative feedback loop. Our downstream substrate is not being produced. Why is it not being produced? Because the patient is on an ACE inhibitor. So we're not making that final step. We're not making angiotensin 2. We lose the downstream effect that would actually inhibit the further release of renin. And so that's why we see elevated renin, because our body thinks we need more angiotensin 2. The problem is we can't actually create it because we're taking a medication blocking the pathway. Now, what's going to happen at angiotensin 1? Well, it's going to be elevated as well. Why? Because our renin is elevated. The body is trying to secrete these molecules, these enzymes, to create more angiotensin 2. But here's where the thing gets a little bit tricky. Our angiotensin 2 is going to be decreased again because the medication is blocking the conversion. It's blocking this step right here, where we would turn angiotensin 1 to angiotensin 2. And a decrease in angiotensin 2 leads to a decrease in aldosterone, which ultimately leads to decreased sodium reabsorption. Again, we're inhibiting the RAS system. Now, we know that angiotensin 2, in addition to its release of aldosterone, does some other things as well. And so we're going to see the opposite of what angiotensin 2 would normally do. We're going to see decreased vasoconstriction. We talked about angiotensin 2 typically wants to increase vasoconstriction and increase blood pressure. Well, if we lose that molecule, we're going to get decreased vasoconstriction and decreased blood pressure. Now, a patient on an ACE inhibitor is also going to experience efferent arterial dilation. This is going to decrease our GFR. Why is that? Well, remember, angiotensin constricts the efferent typically, and we use the memory aid ACE, which stands for angiotensin constricts efferents. So if we block that molecule, we're going to get dilation of the efferent arteriole. And why does this decrease our GFR? Well, we have our afferent arteriole coming in over here, and then our efferent arteriole leaving over here, right? We have a pressure gradient that is essentially pushing fluid into the proximal convoluted tubule. It's pushing fluid to be filtered through Bowman's capsule. However, if we dilate the efferent arteriole and now it becomes a lot wider, let's say something like this, we decrease that pressure because now blood, when it comes in here, it can get filtered here, but it has so much space to leave out the other side, the efferent side, we decrease the hydrostatic pressure, the push through the glomerulus. So ultimately, how does that present? Well, it presents with less of it being filtered overall, which I'm drawing in the green arrow. And that is why we see a decreased GFR in these patients. Next, we have the decreased breakdown of bradykinin. This is a unique one that we need to be mindful of because of the adverse effect that's associated with it. Well, bradykinin is a molecule in the body that can cause bronchoconstriction. This bronchoconstriction can lead to patients experiencing a cough, right? We constrict the bronchioles themselves. It's harder to get air in and out. Patients present with a cough. Well, angiotensin converting enzyme, something typically made in the body, actually inhibits the production of bradykinin. It's a very complicated pathway. I don't think you need to know each individual step. However, you need to be mindful of this association. So what happens if we inhibit an inhibitor and we give the patient an ACE inhibitor? Now we're blocking the thing that typically blocks bradykinin production. And so what happens with bradykinin itself? It's going to increase. The levels are going to go high. And patients who are susceptible to this can actually present with a cough after having an ACE inhibitor. And this is the reason why pathologically it's because there's an elevated level of bradykinin in these patients. Next, I want to move on to the angiotensin receptor blockers. Again, it's really important to think about where do these medications act in the pathway. We know the general RAS pathway, but where this one acts is that it actually inhibits the angiotensin 2 at the angiotensin 1 receptor. This is very tricky and confusing. Unlikely to ask you a question, but it is a nitty-gritty fact to know. Angiotensin 2 binds to the angiotensin 1 receptor, of course. And so again, break this down. What's going to happen to our renin? It's going to increase again because of the same reason. We lose the negative feedback loop. We're going to see elevated angiotensin 1 and elevated angiotensin 2. And this is a really important contrast from what we just saw up here where angiotensin 2 was lower. And again, this is important because they will ask you questions like this. They will ask you about a patient who's on these medications. They will give you a chart with all these different arrows, and then they will expect you to know where the medication acts and how it's going to change the variables. Well, right here is a key differentiating step in angiotensin 2. The reason angiotensin 2 is elevated in an angiotensin receptor blocker is because we're not blocking the creation of angiotensin 2 like we are up here, right? We're blocking the enzyme to create angiotensin 2. Here, we're not blocking its creation. We're just blocking its ability to bind at the receptor itself. And so that's the portion that's blocked here. Now, this is going to lead to decreased aldosterone as well, which is similar to our ACE inhibitors, and decreased sodium reabsorption, again, similar to our ACE inhibitors. And because we block aldosterone and our angiotensin 2 is not in effect, we're going to have similar things occurring in the body to what we just talked about with our ACE inhibitors. We're going to get the same physiologic effects, it's just a different mechanism. Now, finally, I want to talk about the direct renin inhibitors. So these directly inhibit renin. They're going to decrease angiotensinogen to angiotensin 1 and decrease our angiotensin 2. Again, compare and contrast these with the molecules we just talked about. This is going to decrease everything downstream of renin itself. So low angiotensin 1, low angiotensin 2, low aldosterone, and low sodium reabsorption. So these are kind of all talked about in the same video because of their final effects. We decrease aldosterone, we decrease the RAS system, we decrease sodium reabsorption, but their mechanisms matter greatly. And to get questions right on test day, you have to be able to stratify these and say, where does this medication act in the pathway? Now, thinking about our clinical uses here, ACE inhibitors and ARBs are often used for hypertension. Why? Because they can help offload some fluid. They're also used for CKD and proteinuria, in addition to heart failure, history of MI. So let's unpack this a little bit. Why can they be used for hypertension? Well, we talked about they cause decreased vasoconstriction. They're going to drop blood pressure. So that one makes sense intuitively, right? Why can it be used for CKD and proteinuria? Well, these are called nephroprotective medications. And without getting too complicated here, these medications can decrease how much protein is actually excreted in the kidneys themselves. So an early sign of diabetes is often microalbuminuria or proteinuria. These are indicative of kidneys that are failing. They're not filtering the substances as well. And so one of the ways that these medications can help is by this effect over here. By dilating efferent arteriole, less of the protein is actually going to be filtered in the kidneys and more of it is actually going to stay in the body. And over time, this is found to be useful for these patients. Now, what about patients who have heart failure or a history of MI? These medications are known to have what's called a mortality benefit. And while the mechanism is not fully understood, these medications have been shown to decrease cardiac remodeling. So the heart is not stressing as much, it's not having as hard of a time. And that's why it likely has a mortality benefit with patients who have heart pathology. Now, Looking at our direct renin inhibitor, it can be used to treat hypertension, although it's notably not a first-line medication here. The ACE inhibitors and the angiotensin receptor blockers are our first-line treatments. But as we've seen from the mechanism, this medication can also decrease aldosterone, sodium reabsorption, and thus it makes sense why it can be used for hypertension. And finally, talking about the adverse effects here, a very classic one is the association between ACE inhibitors and patients developing a cough or angioedema. And we talked about this previously. This is due to an increase in bradykinin in these patients, right? Typically, angiotensin converting enzyme halts the production or slows the production of bradykinin in the body. Bradykinin is a known molecule that can cause bronchoconstriction. So if we block the inhibitor, right, we inhibit the angiotensin converting enzyme, bradykinin can elevate. It can flourish throughout the body, causing bronchoconstriction for certain patients, leading to a cough. Classic test question is, what are you going to do for these patients? Well, they still need to be on a medication. So we're going to switch them to an angiotensin receptor blocker. We'll stop the angiotensin converting enzyme and switch to an angiotensin receptor blocker. These patients should not have a cough anymore because now angiotensin converting enzyme can have its role in keeping down bradykinin, but the angiotensin receptor blocker is still allowed to have similar effects by decreasing aldosterone and sodium reabsorption. Additionally, this is contraindicated in patients who have a C1 esterase inhibitor deficiency. And the reason is that these patients are already predisposed to have higher levels of bradykinin in the body. Because they're missing this inhibitor right here, they're going to develop high levels at baseline. And so giving them another medication that we know is going to further elevate those levels is a contraindication. And finally, some other adverse effects for all of these medications are going to be the fact that they are teratogenic. So they want to be avoided in pregnancy. They're likely to increase our creatinine and decrease our GFR, at least temporarily. And this has to do with this mechanism over here where dilation of the efferent arteriole is going to keep more creatinine in the body because there's less pressure to actually filter it through the glomerulus itself. Additionally, we could see some hypotension. We talked about why that might be earlier. And some other ones that could show up include hyperkalemia and a rash as well. So again, the most classic board presentation for this is going to be a 70-year-old patient who presents to the primary care clinics talking about they started a new medication 2 weeks ago for their blood pressure. Now they're developing a cough. They don't have any systemic symptoms, and it's really disruptive for them. Well, the first thing you want to do is say, what medications are you taking? If they're taking an ACE inhibitor, they've then developed a cough without any other systemic signs. There's no fevers, there's no chills, there's no signs that they're actually sick. You want to switch that to an angiotensin receptor blocker. And the other classic vignette we already talked about previously is they're going to give you some of these medications and then a table with a bunch of different arrows. And they want you to know these steps, know the differences, know which one has decreased angiotensin 2, which are these two right here. Know the one that has an increased angiotensin 2. Know those differences, be able to compare and contrast. So just in quick summary to wrap up this video, we talked about ACE inhibitors, angiotensin receptor blockers, and direct renin inhibitors. All of them have a similar effect of decreasing aldosterone and sodium reabsorption, but the way they do it is important. So we've talked about the mechanism extensively here, but again, being able to compare and contrast is very important for test day. Thinking about clinical uses here, hypertension makes sense, CKD, proteinuria because of its nephroprotective effects, and for heart failure and history of MI because its medications have been shown to have a mortality benefit. Thinking about our adverse effects here, right? Cough and angioedema are probably the two most commonly tested one. Switching to an angiotensin receptor blocker for a patient who is on an ACE inhibitor is going to be useful, and also be mindful of the fact that these are teratogenic medications. So if a patient comes to you and they have symptoms and signs of hypertension, but the patient is pregnant, we do not want to give them this type of medication. We need to think about some of the medications that would be safe in pregnancy.